All right, team, welcome back to the Cardiac Tumors Masterclass finale. No time to waste, this is the Blitz review to lock it all in. You ready? Let's hit it.
Okay, scenario 1. Adult, left atrial mass, you hear that classic tumor plop. What is it? Myxoma. What do? Surgery. Now.
Flip it. Now we've got a child. Multiple ventricular masses, signs of tuberous sclerosis, that's a rhabdomyoma, and the key here, it's totally different. We just watch it. Why? Because it usually regresses on its own.
Okay, think primary and malignant. See it in the right atrium, causing SVC syndrome? That's your angiosarcoma. And what do you have to fear? Tamponade. Always be watching for tamponade.
But wait, what's the most common cardiac tumor you'll ever see? Trick question, it's not primary at all, it's metastasis. So you've got to check the usual suspects, lungs, breast, or skin, especially melanoma. Remember your imaging tools. Echo is all about motion, MRI gives you tissue characterization, and CT is your go-to for calcium. You got to integrate all the clues, follow that decision tree, and save the heart. Let's go.
Now, before we proceed to our deep dive on the decision tree, we must pause for the mandatory international medical disclaimer.
This content is for educational purposes for international boards only. It is not medical advice. Always consult official guidelines and a specialist physician for clinical decisions.
Okay, now for the deep dive. I've got Sarah here with me, and we're going to walk through the real-world application of this, the decision tree. You know, we've talked about the benign, the malignant, the metastatic tumors, but on your boards and in the clinic, the question is always, what's the next best step?
So Sarah, picture this. You're looking at an echo. You see a mobile mass in the left atrium of a 60-year-old patient. What is the absolute first branch of that decision tree? Where do you go first?
The first question is, primary or secondary, Dr. Collins? While myxoma is the most common primary tumor, secondary metastases are 20 times more frequent. So if the patient has weight loss or a smoking history, the next best step is a CT of the chest, abdomen, and pelvis to look for a primary cancer. If those are clean, we assume it's a primary myxoma and move to surgical resection to prevent a stroke.
Exactly right. You always have to rule out the most common thing first, and that's secondary cancer. Okay, let's flip the script completely. Let's change the age. Now you have a 2-year-old and you see multiple small masses in the ventricles. What's the instinct? Do we rush to the OR?
Absolutely not. That is the Rhabdomyoma branch. These tumors are usually hamartomas, benign, disorganized growths of native cells, and they're strongly associated with tuberous sclerosis. Because they have a high rate of spontaneous regression, unless there is a lethal arrhythmia or severe obstruction, the next best step is watchful waiting with serial echocardiograms.
So it's a complete inversion of management. For the baby's rhabdomyoma, surgery is the last resort. For the adult's myxoma, it's the first choice. That is an outstanding clinical contrast. Perfect. Okay, next scenario. You see an invasive-looking mass. It's in the right atrium, it looks messy, and it's causing a bloody effusion. What imaging do you absolutely need to confirm what you're thinking?
Cardiac MRI, Dr. Collins. We need the tissue characterization. MRI will show us the irregular borders and late gadolinium enhancement, a key sign of scarring or fibrosis, which is characteristic of an angiosarcoma. If we see those vascular channels on MRI, the prognosis is unfortunately very poor.
Spot on with the MRI. Okay, here's a top score question for you. What if the mass isn't in a chamber at all, but it's sitting right on a valve, and it has this weird look, kind of like a small C anemone?
That is a papillary fibroelastoma. It's the most common tumor of the heart valves. Even though it's small, it has a high risk of embolizing to the brain. If it's on the left-sided valves, we usually resect it.
Perfect. That rounds out our deep dive. So now, I want to turn it over to all of you with our question of the day. When you think about what can fool you, which cardiac tumor do you find the most deceptive on an EKG or a physical exam? Is it the myxoma that can mimic mitral stenosis? Or is it that totally silent metastasis? Drop your thoughts in the comments below. We'd love to see what you think.
All right, Sarah, the deep dive is done. Now we lock it in, it's time for the memory chant. This is the decision tree stripped down to the essentials. Ready to encode? Adult, LA, myxoma, plop. Child, multiple, rhabdo, TSC. Right, side, angio, SVC. Valve, C, fibro, embolo. Metastasis is the mass And done. The Cardiac Tumor Decision Tree is now locked in your memory. You have officially mastered the heart's intruders. Huge congratulations for finishing the masterclass. Make sure you subscribe because we're not stopping. Our next high-yield series is on peripheral and aortic diseases. We're going to be tackling the ripping pain. Until then, keep encoding.